Hello everyone, welcome to this second video recording where my colleague and I, Maria and Benson, are going to be focusing on the effect of pregnancy on the human body. Despite the fact that our thesis is mainly focusing on labor epidural, we figured out to give a good anesthesia to a pregnant patient, the nurse anesthesia has to know the different changes that occur throughout pregnancy. Pregnancy affects literally every organ system, either be neurological, respiratory, cardiovascular, GI, renal, and so on. So the first section we're going to cover is the central nervous system. There's a decrease in your minimum alveoli concentration. The reduction is pretty much 40% by term, and that reduction is noted pretty early around your 8 to 12 weeks of gestation, and it returns to normal by day 3 postpartum. There's an increase in your progesterone, which is increased 20 times by term. And because of that sedative effect, it also contributes to the decrease in your MAC value. We also note an increase in your beta endorphins during labor and delivery. During pregnancy, the pregnant patient is quite sensitive to local anesthetics. And this is due to the engorgement of the epidural venous plexus by the gravid uterus. As that epidural venous plexus are engorged, it put a lot of pressure to the epidural space. With that pressure, there's a limited amount of your volume into the epidural spaces. So giving a normal dose of local anesthetic to those patients can actually cause a local anesthetic toxicity. So with those patients, you want to give a reduced amount of your local anesthetic to prevent any sort of toxicity from occurring. So now we're going to cover the different changes under the respiratory system. The oxygen consumption increased from 20 to 50%. Airway resistance decreased by 35%. Your functional residual capacity decreased by 20%. Your minute ventilation, tidal volume, respiratory rate, and PO2 are all increased. Those patients tend to always be short of breath and always kind of pretty hyperventilated. That put them in a respiratory alkalosis state. And there's a decrease of PaCO2 and HCO3 by 15%. So we have more change on the respiratory system. The increase in 2,3-DPG shift the oxyhemoglobin curve to the right. And with that shift to the right, it's going to lower the affinity of hemoglobin to oxygen so that more oxygen can be delivered to the tissue. And without more oxygen going to the tissue, the baby will be able, or the fetus will be able to get more oxygenation from the mother. By the third trimester, the thoracic breathing is favored over the abdominal. Your FRC decrease up to 20% is normalized within 48 hours of delivery. There's a risk of rapid oxygen desaturation with apnea, and this is due to the closing volume that can exceed FRC in up to 50% of the patient when they are laying supine. The respiratory mucosa capillary are engorged, and that could cause a risk of trauma, bleeding, and obstruction. So with those patient population, it might be favorable to use a smaller ET tube, either a 6.0 or 6.5, to prevent such trauma from happening. The next section on cardiovascular will be presented by Benson.
The cardiovascular system, like other systems of the body, are equally affected by the changes of pregnancy. One of the first things that we see in the cardiovascular system is a general increase in our blood volume by 35%. The plasma volume increased by 45%, and our red blood cell volume increased by about 20%. The consequence of all these changes is a situation of dilutional anemia, because the red blood cell volume is small relative to our plasma volume. During pregnancy, generally, there is an increase in cardiac output. Cardiac output is stroke volume times heart rate, and the cardiac output increases so as to be able to make up with the increased amount of blood flow to the fetus during pregnancy. Systolic blood pressure, diastolic blood pressure, and our peripheral vascular resistance, all of these are all decreased during pregnancy. These are all as a consequence of the effect of progesterone on the blood vessel that cause a little bit of vasodilation, leading to a drop in the peripheral resistance and drop in our blood pressure. So always we are expecting a general drop, a decrease in blood pressure during pregnancy. Another effect that we're going to see during pregnancy will be the effects of the graviuterus on the changes in the heart chambers. As the graviuterus increases, they tend to cause an enlargement of the heart chambers. This is because the graviuterus put pressure on the diaphragm tamponates or reduces the thoracic pressures. And remember that the heart is all lying inside your thoracic cavity. So as the diaphragm goes up, it tends to put a pressure on those heart chambers, and they might tend to enlarge a little bit. We might tend to experience, if you listen or if you auscultate to these, to the lungs of these patients, we might tend to hear a type of a systolic ejection murmur. But it is important to note here that most of these murmurs are physiologic; they are not pathologic at all. We may during the second and the third trimester, during the first and the second trimester of pregnancy, as the uterus tend to increase in size, most pregnant women are generally always advised to take a left lateral position when they go to bed. The consequence of this is that if they lie on their right, the graviuterus is going to tamponate their inferior vena cava and their aorta, and that might reduce venous return to the heart. And as a consequence of decreased venous return, you might have decreased cardiac output and that might lead to hypotension. And remember that hypotension, irrespective of the cause in pregnancy, is bad because it reduces blood supply to the fetus, and that might cause fetal hypoxia. So supine position, always left lateral lie. In our next slide, this picture is just depicting the interrelationship graphically of the changes in blood volumes that takes place during pregnancy. Plasma volume increased by about 45%. The blood volume itself increased by 35%, and the red blood cells volume by 20%. And if you can see here, red blood cell volume right down here, the pink ones you see is around 20%. And all of these changes, we're expecting that they go back or they normalize back at the end of the 40-week gestation. Immediately after delivery, everything drops back to where they were before the woman became pregnant. The next slide or the next picture shows us the hemodynamic changes. That means the systemic vascular resistance, the mean arterial blood pressure, and the cardiac output. You see that during the whole gestation period, your systemic vascular resistance tends to drop because we don't want any increase in blood pressure or any hypertension during pregnancy. So the systemic vascular resistance is beginning to drop throughout. Your mean arterial pressure, however, remains constant, but your cardiac output increases because of increase in stroke volume and increase in heart rate. This is to make up with the fetal demands during the gestation period. And the next slide is going to be taken over by Ari.
Hello, everyone. We will be talking about the gastrointestinal effects the pregnant woman faces during pregnancy. So we normally see gastroesophageal reflux and esophagitis, and this is all due to an increase in progesterone. An increase in progesterone causes an incompetent cardiac sphincter, also known as lower esophageal sphincter, and this causes a reflux of gastric acid into the esophagus. We also have an anterior displacement of the stomach. Also, you have an increase in placental gastrin, which causes hypersecretion of gastric acid, although there's no changes in gastric pressures. These patients are normally raised for regurgitation and aspiration. So these patients are considered full stomach due to this. So during general anesthesia, by the 12th week of gestation, patients need to do, well, CRNAs need to do a rapid sequence induction with any general anesthesia to prevent aspiration. And aspirations can be exacerbated by opioids and anticholinergics. There is no research that shows this decrease in gastric emptying, but gastric emptying decrease can occur during labor. Some of the hematological effects experienced are a hypercoagulable state. So there is an increase in fibrinogen and factors 7, 8, 9, 10, and 12. There may be a decrease in factor 10 and factor 13. So it means the patient are more likely to form blood clots during pregnancy, and also with the increased formation of blood clots, also have an increase in fibrinogen, which causes an increase in breakdown as well. Patients are at risk for viral infections due to depressed immunity. There is a decrease of 10% of platelets in the third trimester. So we will always want to check a platelet count prior to doing an epidural or a spinal, because we don't want a epidural hematoma formation due to an increased risk of bleeding. There is an increase in mineral corticoids, which causes sodium retention and causes an increase in body water. You have a decrease in plasma proteins, which is delusional. And so this affects the drugs that are protein bound. Some of the renal effects are an increase in renal blood flow, and this is due to vasodilation. The patient's autoregulation is preserved, and autoregulation occurs with a MAP of 50 to 150. The kidneys will be enlarged as well, and there will be an increase in GFR, roughly 50% during the first trimester. This will normally normalize by the third trimester. The serum creatinine, the BUN, may also decrease. They will experience mild glycosuria, mild proteinuria, and they also have a decrease in plasma osmolality. There is not much changes in the hepatic system, but we will see a decrease in serum pseudocholinesterase, roughly 25 to 30%, but this hasn't shown to lengthen the time of succinylcholine action. This decrease in serum pseudocholinesterase should return to baseline within 6 weeks postpartum. Patients are at risk for gallstone formation, and this is also due to progesterone, which causes a decrease in cholecystokinin. Metabolic changes that they face are more favorable to fetal growth and development. Patients will have low blood glucose and amino acids. They'll have more free fatty acids, ketones, and triglycerides. They will be in a diabetogenic state, so the insulin levels will increase throughout pregnancy. They will have insensitivity to insulin, and this is due to HPL, human placental lactogen. And also they will have hyperplasia of the pancreatic B cell. The thyroid will experience hypertrophy, and this is due to elevated estrogen levels and human chorionic gonadotropin, they just say HCG, and you have an increase in thyroid binding globulin. You have an elevated T3 and T4. Your TSH and your free T4 and your T3 will be normal. And lastly, we will talk about the musculoskeletal effects. This is all due to an increase in relaxin. An increase in relaxin causes a softening of the cervix, and there's also an inhibition of uterine contractions. And you also have relaxation of the pelvic joints and a pubic symphysis. You also have laxity of the spine due to relaxing. This contributes to an increase in back pain during pregnancy and patient at risk for back injury as well. And they also have increased lumbar lordosis. And that concludes this lecture series for today. And we want to thank you guys for listening to our lecture. If you guys have any questions, feel free to drop them at the comment section below. And you can also put your questions in the WhatsApp forum as well. Like I said, thank you once more.